So let's start. I think Rajiv, you have the first
Yeah.
paper. Yeah, start sharing your screen.
Okay. Am I audible?
Yeah.
Yeah.
Yes.
Okay. So I'll be presenting, I'll be reviewing first paper today. That's on obese children have different forearm fracture characteristics compared with normal weight children. So this is a level 3 study. The background is the child obesity rates in USA is highest in the world. 1/3 of children and adolescents in the age group of 2 to 19 years are overweight and 1 in 5 are obese. So forearm fractures and obesity have a peculiar association. Up to 44% of overweight and obese, they have increased the risk of failing initial non-operative management requiring remanipulation. And they have assumed that thick soft tissue envelope gives the plaster less of mechanical advantage and fracture alignment maintaining becomes difficult. The purpose of the study was to compare forearm fracture characteristics in overweight and obese and normal weight pediatric patients and to investigate whether there is a difference in failure of initial non-operative management and complications. Their hypothesis is the soft tissue envelope places them at a less risk of sustaining open fractures. So it was a retrospective study in the age group of 2 to 17 years. Patients included in the years presented in the years January 2010 to September 2017, and they included low energy trauma such as playground injuries, ground level falls, and sports injuries, and they excluded patients with incomplete height and weight data, underlying conditions that predispose to fractures or altered fracture healing such as torus, green stick, pathological and high energy fractures and ipsilateral upper extremity injuries. All patients were managed in emergency with splinting. Close reductions were done under conscious sedations by orthopedic residents, and then they were followed up after 1 week with pediatric orthopedic surgeons. The demographic data was read in terms of age, sex, height, weight, BMI, and BMI for age percentile. They studied the fracture characteristics such as closed or open, the locations, which bones were involved, fracture types, and associated neurovascular injuries, compartment syndromes, initial fracture managements, failure of initial non-operative treatment, and treatment complications. They labeled as failed conservative treatment if the patients underwent additional treatment for their fractures because of unacceptable fracture alignment as determined by the pediatric orthopedic surgeon at follow-up visits, and complications such as neurovascular injury, infections, skin breakdowns, or fracture displacement after surgical fixation, and implant-related delayed unions and non-unions. So they had defined normal weight patients as those patients in whom BMI percentile was less than or equal to 84, overweight as 85 to 94, and obese when it was more than or equal to 95. The statistical analysis was by independent t-test for continuous variables and Fisher-Exat test for association between groups and categorical variables. Coming to the results, so they had total 565 patients. Overweight patients were 77, obese patients were 85, but there was no difference in age, sex, fracture laterality, whether right or left, or history of previous fracture in the same forearm. The normal weight children sustained open fractures nearly twice as overweight and obese, but this was not statistically significant. The numbers were 39 versus 8 with a p-value of 0.065. All the open fractures in OW+OB group were grade 1, and normal weight group had grade 1 85% and grade 2 15%. The fracture characteristics on the location part, the overweight had more of a distal fractures. Amongst the bone involved, the isolated radius was more common in overweight, whereas isolated ulna was more common in normal weight. And the fracture type, the Monteggia fracture was more common in normal weight. In both the groups, the results were similar in terms of initial treatment, whether it was a non-operative, operative, failed non-operative, complications requiring more than one surgery. The results were almost similar in both the groups. So first, they claim that it was the first study that had evaluated differences in forearm fracture characteristics in normal weight children compared with OB plus OW peers. Normal weight patients had 4.1 times higher risk of open fracture than obese who have thick soft tissue envelope. There is a significant relationship between BMI percentile and fracture type and fracture location, such as obese had isolated radius more common and normal weight children had isolated ulna, and the reason being subcutaneous border with little soft tissue cover. Compared to the previous studies, such as by Manning, Ryan et al., children with forearm fractures resulting from ground level fall were more likely to be obese compared to those with major trauma. They had a biomechanical analysis using computer simulation models, and when hand had a contact during fall out outstretched hand, the risk was equal. So if arm had a contact, then the obese have more risk. Also, obese had issue of balance and greater difficulty in bracing their fall. But the results did not show higher rate of failure of initial non-operative treatment in overweight. 38% of normal weight and overweight plus obese failed initial non-operative treatment, comparable to the rates reported in other series. And the limitations of this study are, it was a retrospective study where data collection was dependent on accurate documentation in medical records. The initial fracture reductions were done by a large number of orthopedic residents with varying levels of experience. Initial immobilizations were done in splints, so cast index could not be calculated. Follow-ups done by pediatric orthopedic surgeons who may have had different criteria for acceptable reductions and remanipulations, and forearm circumference was not measured. So they concluded that overweight plus obese children and adolescents, they have different forearm characteristics compared to the normal weight peers. Normal weight children have 4.1 times higher likelihood of sustaining an open fracture, suggesting thick soft tissue envelope is a protective factor. Distal forearm fractures and isolated radius fractures are more common in obese. And in contrast to previous studies, obesity was not associated with failure of initial non-operative treatment or a higher rate of complications.
Yeah, thanks, Rajiv.
Yeah.
So I'll just make initial comment and then everyone. So a good presentation, Rajiv. What I want to say is obese people have less contact sports. That may be a reason why they may be having less open fractures and less severe injuries, which need to be managed by an operative management. But if you have similar characteristic fracture in a thin child versus obese, for example, a displaced radius ulna fracture in a thin child, you may treat with close reduction and plaster. In an obese child, the same fracture may have to be treated with elastic nailing. Yeah. So that's the difference. But overall, if you see whatever, sort of obese children I have treated, the fractures have not been severely displaced in them because the energy of fall is not, they don't have sort of high energy trauma. They don't cycle or run or take part in sports. They will just have, just losing balance and get fractured.
Yeah. Low energy falls.
Yeah. Any other comments on this? Okay. So learning point is that, it just describes this fracture. We don't deal so much with obese children. So in terms of treatment methods, there is not much to gain from this paper. Okay. Yeah. So who has a second paper?
So that's mine.
Yeah, Jay.
So I'll be talking about the reverse oblique supracondylar fracture. It's a new pattern which is described, published last year in the JPO. Paper is from the orthopedic department at New Orleans in New Jersey in the US. So the background to this is this original paper in 2008, and I'll share this paper with everyone, where they described all these oblique patterns, both in the coronal and sagittal plane. This is from Sponseller's unit in Johns Hopkins, Baltimore. And they basically said that if you have a sagittal oblique pattern, which is more than 20 degrees of angulation on the lateral view, then your rates of complications are slightly higher. And in their series of some 300 patients, the amount of sagittal obliquity, higher sagittal obliquity was about represented 40% of all fractures. But note that the sagittal oblique pattern goes from anterior cortex distally to posterior cortex proximally. So that's the classic sagittal oblique pattern. So in contrast, this current paper describes the opposite pattern, where you have a anterior cortex proximally to posterior cortex distally. So on the lateral view, it is the opposite obliquity of the typical high sagittal obliquity pattern. I hope everyone's clear with that. Yeah. So in the typical sagittal oblique pattern, you have an anterior spike. Here, which anterior spike on the proximal fragment. Here, the anterior spike is on the distal fragment. And that makes reduction difficult because the spike goes and impinges on the proximal fragment as you try to reduce it. So they included all pediatric supracondylar fractures from 2014 to 16 with this particular reverse oblique pattern. So that's what I've described, anterior cortex proximal to posterior cortex distal. And they included all extension type 3 and 4 fracture patterns. And type 4 fracture pattern, as you know, is a intraoperative distinction that you make. It's not obvious on the pre-op radiograph, but when you try to reduce it, it's very, very unstable, and that's a type 4 Gartland fracture. So they had 299 patients of supracondylar fractures. This is all supracondylar fractures that they managed over the 3 study years. They looked at age, sex, and BMI, neurovascular status, whether there was antecubital ecchymosis or not, which is an indirect indicator of the amount of soft tissue injury. They also looked at post-op range of motion, need for reoperation, and any other complications. They also looked at the direction of displacement, pin configuration, and number of pins used. And they also looked at associated fractures. So what they did was to use Skaggs's classic reduction technique with longitudinal traction with the elbow and 30 degrees of flexion. But before they did the last movement, they actually translated the distal to proximal. So they moved it. So they did not correct the lateral translation. They just gave inline traction and then pushed the distal fragment anteriorly and then did the standard Skaggs reduction. That was just to get that anterior spike on the distal fragment to back to its normal place. So they converted a reverse oblique into a standard oblique type reduction. So this is the actual distribution of all the patients. So they had, according to this diagram, they had 13 reverse oblique fractures, but in the results, they've said there are 12 reverse obliques. So that's an editorial mistake. So reverse oblique pattern had a significantly higher risk of antecubital ecchymosis and anterior intraosseous nerve palsy. So 50% of type 3 fractures that had reverse oblique pattern had anterior intraosseous nerve palsy, compared with only around 14% of type 3 non-reverse oblique. So the overall soft tissue injury was also higher in terms of nerve palsy, pulselessness, and compartment syndrome. So reverse oblique pattern is a marker of higher soft tissue injury. So these are the actual tables presented where they showed significantly higher incidence of antecubital ecchymosis, anterior intraosseous nerve palsy, pulselessness, and compartment syndrome in the reverse oblique pattern compared to non-reverse oblique pattern. And this difference was even more apparent when you selected only type 3 fractures. So present paper had comparable rates of all complications compared to other series. These are injury-related complications. They did not require any open reductions because they modified this technique. And one of their hypotheses is that one of the reasons other series may have had a higher open reduction rate is because they encountered this difficulty wherein they were not able to reduce. So they are saying in a reverse oblique pattern, if you actually do this slight modification of technique of translating this fragment, then you can avoid open reduction. And that's the main message from this paper. But it was treated by 6 different surgeons, small sample size. The total number of reverse oblique pattern cases only was 12 or 13 cases, depending upon which part of the paper you read. It was a retrospective case note review with all the limitations of that. So they recommended a further prospective multi-center study. Papers open for discussion.
Nice. So any experience, anyone has encountered this in practice? We need to look back. We need to look back our cases and see.
Well, what the mind doesn't know, the eyes do not see. That's the problem. Now I have to go back and think which one of my supracondylar fractures were reverse oblique. But we'll start looking at it now. Now that we know about this pattern, I think all of us should look at this.
Because I'm sure geometrically this is not easily reducible because the plane of reduction and plane of the fracture are different. And it makes sense that you circumduct the fracture, take it around and get it into a plane where you can, so convert into a flexion injury basically. You know, get the fragment anterior and then reduce. I don't know what is the effect of flexion on this. If you give more flexion, but it looks that it should stay reduced with flexion. And secondly, they didn't talk about the direction of pinning, is it?
I don't think they had only about 12 fractures. There were no differences in the way they pinned it. So the pin configuration was not different between the.
It will be same as transverse because normally we go from anterior to posterior, and this would allow that. This will allow that.
So it's a simple paper with a neat message, and it's something, my eyes have been open to a new supracondylar pattern, and I'll keep an eye out for it. That's all. And also a higher rate of anterior introsseous nerve palsy and things like that.
Yeah, have they mentioned that nerve palsy happening during the manipulation technique or something like that?
I think no, that was pre-op. So they had pre-operatively documented.
All of them were pre-op.
Yeah, all of them were pre-op. So this was not a post-operative complication. And they also mentioned this antecubital ecchymosis, which was significantly higher. So there's a greater amount of soft tissue injury. So it's probably a slightly different mechanism of injury that causes this reverse oblique pattern to happen. So
any radial nerve palsies in these cases?
No, they had more of anterior introsseous nerve palsy.
So we can, I mean, the coronal translation, that means is happening towards the medial side mainly. Because with an anterior spike, the radial nerve should also be at risk, at least.
So all of these fractures, all of the reverse oblique fractures were actually post-lateral displacement. All of the
then predisposed to median injuries. Yeah.
Median, yeah. Good. Nice. I think Mandar, you can share.
Just share my screen. Can you see my screen, sir?
Yeah.
So this paper is on traumatic posterior hip dislocations in children and adolescents. And they have compared between MRI and CT scan for detection of some intra-articular pathologies. And now this is basically has come from Children's Hospital Boston. And they have one radiologist on the team and one from Boston and one radiologist from Thailand who have analyzed the CT scans and MRIs. So it's like a combined paper from Thailand and Boston. So the aims and objectives were, just one second, to review the MRI findings of traumatic posterior hip dislocations in children and adolescents. And they wanted to compare the MRI with CT scan findings in terms of finding structural abnormalities that will have an impact on management approaches. That is that was the purported aims and objectives. In the patients, there were about 45 patients which they analyzed between a study period of almost 14 years. The inclusion was anyone who was below skeletal maturity, below 19 years of age, and where they had a post-reduction MRI. So the availability or non-availability of CT scan was not a finding, not a criteria. So with these criteria, about 18 patients were excluded. So the 27 patients were included in the studies. All of them had post-reduction MRI. But out of the 27 patients, only 16 of them had undergone a CT scan simultaneously. So it's not as if that all patients who had MRI also had CT scans. So what they were documented, what the findings were documented on CT scan and MRI were all this, where CT scan predominantly found bony changes, while the MRI found bony as well as some cartilaginous changes or soft tissue changes, which is this. So I'm going to elaborate that as I go ahead. In the results, the average age was about 12 years. It was usually a very high velocity injury, either a sports related injury or a motor vehicle accident. What was very interesting is this. The median duration from injury to MRI was almost 3 weeks, almost 21 days. And the range was about 1 day to 52 days. So it was a wide range of timing from the injury to the MRI that was done. That is one. And secondly, the MRI and the CT timing were not correlated, which means that some of the CTs were pre-reduction, while some of the CTs were post-reduction. So again, it was not a very comparable study between a CT scan and MRI. And then we have a very busy slide where they have documented CT scan findings in almost 50% of cases. MRI also were comparable, but if you just break these various numbers down, what we found is this, that labral entrapment, if you see that it was found predominantly on MRI, and cartilaginous acetabular fracture was found predominantly on MRI. So this is a finding which we are expecting, that we are expecting that soft tissue involvement is more on an MRI. But what they found is that they found one where the posterior osseous acetabular fracture was more detected on the MRI, which is again a different finding. And secondly, though the equal amount of intraarticular bony entrapment is seen in CT as well as MRI, what they could found is that the donor site could be found more easily on the MRI rather than on the CT scan. So these are two findings which were slightly newer as compared to what we thought. So what they have said is something which we usually know, that we know that labral entrapment is a known cause of failure for close reduction. And what they have found that CT scan underestimated the size and displacement of the posterior wall fragment. So this, especially in children who are less than 13 years, where there is a large amount of cartilaginous segment, it underestimated the size of the posterior wall fragment. And MRI was actually better than in detecting osseous injuries. But however, they have not given any statistics. It's a very small series and it is very difficult to have any statistical significance to this. And as expected, MRI could detect early AVN. That is what they have said. A big limitation of this study is that retrospective, it's not a controlled study. It's not a good case control where every patient who has undergone an MRI has also undergone at the CT scan and at the same time. Because again, as I said, it is between 1 to 52 days of MRI findings, and CT scan they have not mentioned, but some of the CT scans have been done prior to reduction, which again makes a difference. And they have said that there 12 patients out of the 27 were operated. However, they have not corroborated the MRI findings with the intra-op findings. They have just left it slightly open. They have not corroborated that these MRI findings are proven exactly equal as compared to the intra-op findings. So this was so overall, it was a study which did not add much to our understanding. It's basically said that even for osseous injuries, MRI may be better as compared to a CT scan, where probably better studies are needed for an exact conclusion.
Yeah, thanks, Mandar. Well presented. So there are three issues which comes. One is that what are the findings and what were the operative findings, and secondly, the surgical rates. So by doing MRI, did you pick up something which you would not do on CT scan? In fact, I remember Sheetal mentioning was that if there is loss of reduction, you are going to operate anyways and find out what is the issue. So, and it's easier to do CT than MR, but I agree that if MRI would be definitely a choice. And the one thing is that do you do it post reduction or pre reduction? So once you have a hip dislocation in a child which is traumatic, do you do MRI and then reduce and then do MRI again, or you reduce it first and only if the reduction is non-concentric will you do MRI.
So what they have done is done a emergent reduction in every patient, except in some of them where they have done a CT scan. There was no pre-reduction MRI which has been done. They have a few pre-reduction CT scans which were done. That is one. Secondly, they have done MRI or CT scan in every patient. It's not as if they have found non-concentric reduction clinically or on an X-ray, and they have done MRI in select number of patients. They have done MRIs in all post-traumatic posterior dislocations with or without concentric reductions. So that is probably a power of the study, that they have found some labral injuries, something which are seen even in concentrically reduced hips, and that is what is more important. So I think that is one USP of the study.
So in concentrically reduced hip, if you find an additional labral injury, would you operate that or keep under observation?
Probably not. Probably not. So that is what, unfortunately, they have not said in their papers.
Right. Right.
But logically, we feel that it should be that if it's a concentric stable reduction, we hold on, especially in a very young child.
Okay. Any other questions? Discussion. Okay, let's go to next one. Ankita, please share your screen.
Good morning, sir. Am I audible?
Yes, very well.
The paper is relationship between severe disease and skeletal maturity, and this was done in 2 centers, that is at Cleveland and at Yale University, New Haven. Severe disease is an inflammatory condition of the calcaneal apophysis, which is speculated to be overuse injury, which is with no external or radiographic features, and it occurs generally between 8 and 15 years of age. So the authors have hypothesized that severe disease occurs in a relatively narrow range of skeletal maturity, and they have used the calcaneal system to assess skeletal maturity. Now, the stages of calcaneal maturity occur in 6 stages, with 0 being no ossification of the apophysis. Stage 1 is the apophysis extends more quickly over the plantar than dorsal surface. Apophysis covers less than 50% of metaphysis. This occurs roughly around 4.7 years before the peak height velocity. Stage 2 is the apophysis covers more than 50% of the metaphysis. It has not extended to the plantar edge, in roughly around 2.11 to 1.15 years before the peak height velocity. Stage 3 has complete extension over the plantar surface. The apophysis extends within 2 mm of plantar edge, and this occurs roughly 0.86 years before the peak height velocity. Stage 4 is when fusion of the apophysis to the metaphysis starts, but there are still intervals between the apophysis and metaphysis, and this stage of fusion generally occurs over a period of 2 years. And fusion of the apophysis, stage 5 is fusion of the apophysis, which is described as when the fusion is complete or has just started to be completed. This occurs roughly 2.1 years after the peak height velocity. So the study was a retrospective study from a database, and it included all patients, females between 5 and 15 years and males between 8 and 17 years who were diagnosed with severe disease, who had, and they could have had an X-ray, they could be without an X-ray. So the X-rays of the patients that did undergo radiographs within 6 weeks of the diagnosis were graded according to the calcaneal skeletal maturity system. And after this, they found controls which were matched in by age in years, race, and sex of people or children who had X-rays, calcaneal X-rays. So there are a total of 39 patients with X-rays and 39 without X-rays, giving a total of 78 patients. So mean calcaneal score was 2.2 plus minus 0.8 for all patients with X-rays, 2.1 for male individuals and 2.3 for female individuals. Now, the chronological age overall was 10.1 plus minus 2 years for patients with X-rays. In males, it was more as compared to females. Without X-rays also, there was no significant difference in the chronological age of patients with or without X-rays, but an overall significant difference was found between males and females who were presenting with severe disease or who were diagnosed with severe disease. So 95% of all their patients fell in the stage 1, 2, or 3, with the majority of the patients diagnosed with severe disease lying in stage 2. So they have said that although there is a difference in chronological ages between male individuals and female individuals, there is no difference in calcaneal skeletal maturity score. Then theoretically, before stage 1, there is no bone in the calcaneal apophysis, so you can't ideally diagnose severe in this. During stage 1 to 3, bone has formed in calcaneal apophysis, so overuse may produce enough inflammation and micromotion at the apophysis to lead to irritation. At stage 4, there is eventual enough fusion to stabilize this micromotion, and then ideally speaking, or theoretically, stage 4 severe disease, stage 4 calcaneal maturity patients or stage 5 calcaneal maturity patients should not cannot be diagnosed with severe disease as per their discussion. So the limitations of this study was that it is a retrospective study with a selection bias. They have not defined criteria for diagnosing severe, and then they haven't defined criteria, or they have not randomized as to which patients had radiographs and those who didn't. That's it. That's the study, sir.
Yeah. So actually, there are a lot of studies where MRI has been done, and they've said that though what is evident on X-rays in sclerosis of the calcaneal apophysis, this disease is not of calcaneal apophysis. It's a sort of a subchondral fracture in the calcaneal body, which manifests because of increased the vascularity changes as increased sclerosis in the apophysis. So so this is, there are few, so I really don't know if that is relevant anywhere in this series.
Has anyone ever had to treat in any way Sever's disease? I don't know. It's a benign self-limiting condition.
Right.
What is the? I just don't get the relevance. What exactly is the takeaway message? The clinical applicability of this?
No, nothing at all, because but they just have correlated to the radiological staging, because the X-rays are available, field X-ray, and somebody decided let's do the staging, and they found that stage 2 was most common. That earlier part of healing it occurs. So
that kind of makes sense.
Yeah.
That is the maximum stage of growth.
So it is something which is known, and you're proving it, and making it into paper.
Correct.
But so I think we should sometime look at all these benign conditions and see, because many of these guys do have vitamin D deficiency. We really don't know it is coincidental or it is cause and effect relationship. And but we do see nowadays, there are the number of patients I see with severes are there are few patients which add to your OPD numbers, and again there are a couple of patients I had to put in plaster because this was these are microfractures. That is what Tushar is saying.
You mean
metaphyseal
microfractures in the apophysis?
No, metaphysis. Metaphysis. So
calcaneal body.
Yeah. So I'll just sort of share that paper on the WhatsApp. Yeah, please.
Yeah. Is there any way of knowing what is correct vitamin D in children? Because we seem to be blaming everything on it.
Yeah. No, really, because there is one big review on vitamin D, which is done from several countries. Even they don't know. So what we label as insufficient and deficient and normal range, no one knows what is normal.
Yeah, because we seem to be blaming each and every condition on vitamin D deficiency in children.
But there are some conditions like slips we have seen really low.
Yeah.
So there is a correlation. Most of the slips we see, they are really, really low. So somebody will have to do this study, and we don't know when we say low vitamin D level and child is asymptomatic, what does it mean? Really, no one knows.
So I was discussing this with Dad about the levels of vitamin D. So what he said was it's not just the vitamin D levels, but the parathyroid response which is more important.
Okay. Right.
So So especially when it's a symptomatic child. So many a time we feel that it's a very non-specific thing and we just give him vitamin D, that's fine. But if it is associated with something like a slip or something which is structural or important,
PTH.
it is important to do a PTH level. And the parathyroid response usually, it may not be in the primary hyperparathyroidism range, but at least in that in the low hundreds or so, if we find that, then that is significant. So because say if we do our vitamin D, it may be say 10 or whatever, but we are not symptomatic. But so a symptomatic proper child who has say probably osteomalacia significant or something of that sort, that PTH needs to be done.
And vitamin D level at which needs to be treated. We really even don't know that.
Correct.
Yeah, Tushar. Yeah.
Okay, so am I audible?
Yes.
Yeah, okay, great. So this is a JPO 2019 article level 3 study, and they are reviewing 8 plate, which they are actually calling a tension band plate, because they don't want to label it as to attributed to any one particular company manufacturing it. And they are giving a 10-year experience from one center. And the principal author is Mohit Jain. Okay, so this is Mohit Jain. So it happens that he is educated from BJ Medical Ahmedabad. Okay, and he is currently in Texas Children's Hospital. This is how Texas Children's Hospital appears. So it is currently in this year number 4 in list of Children's Hospital and number 10 in the list of top 10 pediatric orthopedic hospital. So they seem to be having the top 3 centers in Texas in terms of children pediatric orthopedics. And these are the other publications of Mohit Jain, very heavily published in this current year, but on diverse topics like adolescent scoliosis and osteomyelitis and septic arthritis. So the background of this study was that we are now predisposed ever since Peter Stevens came. So the 8 plates are we are biased towards using 8 plates as the treatment of choice for angular deformities. And we also know that they have a very high failure rate in Blount. So they thought that we should characterize the predictors for the failures. So we know it fails, but we got to use it. So let's assess what to do about it. So the previous studies did not accurately comment on the cause of failure. They did comment that it fails. So the hypothesis here was that the failure rate of tension band plating is high in Blounts is high, and they wanted to compare their study to find whether they've got a sort of a comparable rates of failure or success. And they have defined 2 types of failure here: a surgical failure and a mechanical failure. The very interesting thing is how they classified their moderate and severe Blounts. Okay, so they take this long axis film and the hip knee axis deviation. That means very obviously the mechanical axis of the tibia to the full mechanical axis they're taking that as one angle, and the metaphyseal diaphyseal angle, the Dineen's angle, that is what they are taking as the second angle. They sum it up and divide it by 2. So that sort of takes the whole limb to the tibia proportion very well. So I didn't find this kind of measurement of varus in any of the previous papers or any of the papers following this, because everybody is monitoring the metaphysio diaphyseal angle only. So they are summing up the 2 angles and dividing by 2, and they call anything between 11 to 20 as mild and more than 20 as 11 to 20 is moderate and more than 20 is severe. So they reviewed patients between 2008 to 2017. So 2007, I think Peter Stevens' paper was published. So following that, for 10 years, whatever they have done, they've taken a review, and then they characterize it on the basis of deformity, age, obesity, and implant, whether they have used cannulated, non-cannulated screws, and what metal, and how they have placed the implant, whether they are placed on distal femur, upper tibia, or only the upper tibia. Now, how do they define their failures? So they define a functional failure as one which is less than 50% deformity correction at final follow-up. which is never less than 6 months after the index surgery. Okay, so this is very important, less than 50% of deformity correction. And second is the definition of surgical failure was into mechanical failure. So mechanical failure was implant breakage or screw breakage or back out. So there is a there is a failure, mechanical failure, and then there is a failure of correction. So there are two types of failures which they are taking into account. So they studied a cohort of 40 patients with 61 limbs, which is very high for Brown's disease. So it's a good number of patients. I didn't find similar number of patients in anybody else's study. Okay, and they had comparable rates of surgical failure as compared to the studies which they compared. So they found a 41% overall surgical rate failure, of which 11% were mechanical failure rate. Means 11% were metal failure rates, and overall 41% patients failed to correct. Okay. All the 7 cases in which they had mechanical failures involved breakage of cannulated screw on the metaphyseal side. So there are 3 things here: deformity, plate material, and obesity. So these are the 3 things which they have found to be very significant. So how severe was the deformity? Is the patient obese? And what was the plate material? Okay. So they found comparative failure rates as compared to any other study. However, also comparable to the multicentric Posner review, where they reported 15% mechanical failure, they had 11% mechanical failure. So these are the significant p-values: high body mass index, high deformity levels at the time of surgery, and the plate material and screw. So interesting feature is that the age of onset, I think I failed to mention, they divided patients into 2 criteria, that is early onset and late onset. So early onset is below 4 years and late onset is after 4 years of age. Somehow it skipped in the slides. And the implant design was not really statistically significant. So if you are using a 4-screw design, or you are using a double 8 plate, they don't seem to be having a very high rate of experience on that. So again, the statistics prove that the more severe the deformity in which you apply the 8 plate, and if you use a titanium plate with cannulated screw, then the failure rate was higher. Again, this graph will show the same thing, that deformity and a higher body mass percentile. So if you see in surgical failure, when they say yes, okay, so that means the patients are in a high 98 to 99% obesity percentile, whereas these are 76 percentile patients, the ones in which there is no surgical failure. And the deformity also is much less, 18.8 as compared to 25.8 in the case of surgical failure. So more deformity at the time of application. Similarly, for patients with surgical failure, when there are no surgical failure, if you see here, that means they have used a steel plate. So titanium plate, yes, surgical failures are more, and when there is no titanium plate applied, there are no surgical failures. This is no surgical failure, numbers are higher. So that is statistically significant. So what are we coming to is that they are saying that the metal is very important, and to use a solid screw is very important. They query on the implant design. They are not very certain that whether the results can be improved by changing the implant design. However, they feel solid screws to be applied in all obese patients with severe deformity. So their final recommendation is that you can continue using 8 plates. However, it should be a stainless steel 8 plate with solid screws if the patient deformity is of the severe nature and if the patient is obese. Now, in their conclusion, in the abstract and their final conclusion, there is some sort of confusion. What they are saying is that they have a 40%, 41% surgical rate. but that should not restrict your use of the 8 plate as or the tension band plate in Blount's disease, as it still do have close to 60% success rate. So you can continue using the Blount's, the TB, the 8 plate. However, you have to take care of these 4 factors: obesity, significant deformity, and you should use a SS plate with a solid screw if you want to get a good outcome. In the initial part of the abstract, however, they mention that in Blount's disease, it is still to be proven in totality, and we can still continue studying the implant design. So final take is that we are preconditioned to using 8 plates now. Though we expect failure, still we use it. So to improve outcomes, I think they give a lot of statistics in favor of a stainless steel plate with a solid screw. However, there are some other causes of failure also, like implant placement. So I think we should be very accurate in every aspect of the surgery to get a good outcome. And maybe in the older child, using 2 parallel 8 plates with 4 screws may give us a better outcome. Studying the distal femur very closely, an application of 8 plate there may give us a better outcome. And Sandeep Patwardhan is here, so we had discussed this. Sometimes it is noticed that they do not contribute to the tibial torsion, and that may take away a good result. So in list of references, Patwardhan's article was reviewed by them. Sabharwal's article was reviewed. The main articles which keep getting reviewed are Herzenberg's article, and Kadim's article has been reviewed for the technique of application of the solid screws. And this is an important article which gets reviewed by all very first, very early in 2009, they came up with the failure of the 8 plate in Blount's disease. Okay, so we have a 60% sort of success rate. It's a 60-40 success rate. To improve, we use SS plate with solid screws. I just took the liberty of showing the other papers. So this is the Samuel Schorak's paper where he comments on failure, but he has just hypothesized that probably obesity and deformity was the cause, but he could not prove it because it was very early outcomes. This is Peter Stevens' paper which has come out in 16, but I think they have a huge bias in their result because they are giving a very high success rate, because most of the patients which they involved were of the moderate Genovarum, if you see their clinical pictures in the paper. And this is the latest paper on Blount's 8 plate. However, they are all early onset patients, so they've got a better outcome, and they are commenting more on the relapse rate. Thanks a lot.
Okay. So any comments on this? So yeah. So one issue which you brought about was failure of correction, and second was implant failure. So if they correct too fast, then there'll be implant failure. But if they don't correct at all, then there'll be failure of correction. So these 2 issues remain.
I don't think I could make that if the speed of correction is fast, then there is implant.
They have not mentioned that.
No, I don't think so. Not that I could pick up from the paper. What I feel, what they are saying is that each and every 8 plate failure, mechanical failure, is of screw breakage at the metaphyseal site.
Right.
So I think they have a very strong recommendation that we should use stainless steel plates, and we should use solid screws.
Kirti, I don't think it has anything to do with the plate, because the plates don't break. In the obese children, I use two 8 plates stacked on one another, and I always use solid screw. And in India, the problem with the titanium plate is that there is a collar. There is a non-threaded portion of the shaft between the head and the threaded portion. So that should not be there. So the thread should go all the way from the tip to the base of the head of the screw. And most of the Indian 8 plate designs, if you see, there is a small collar, and that's where it breaks. So
you are recommending a fully threaded plate.
Why that is there, I'll tell you. Because that sort of mechanics is copied from a normal cortical screw of a DCT. It is inherited from that. They have not bothered to change it, because that same die or same punching has been used. Ideally, it should be designed separately. The screw head of a tension band plate should be completely separate. Design. Yeah,
So
Kirti wanted to say.
in this article, when they were showing measuring the angles of blount, how severe is the blount, the affected side was rotated. If you see the femur, it was externally rotated. Will this make a difference in the findings with the
I
severity?
don't think it's rotated. I think sometimes it's difficult to get. In other articles also, I am seeing in the severe blounts, their scanograms are appearing like this. Even in the Peter Stevens article, if you see in detail.
So probably because of the internal torsion of tibia, they are aligning the tibia, the shin perpendicular.
Possible.
Yeah,
In
and
the
so the
direction of
femur rotates. Yeah, so the femur rotates.
Right. Okay, so let's please unshare, Tushar. Let's go to Kirti's review article. So what I request everyone next time, we'll have to keep a time limit. Let's follow Bandar's criteria, and rather than we tend to become more descriptive in explanation. So either we'll take a poll and see if you want to have less number of papers and more time per paper, or more papers and less of description. So anyway, Kirti will review this paper on what is new in pediatric limb lengthening and deformity correction. Yeah, Kirti.
I'm audible and you can see the screen, right, sir?
Yes, yes.
Yeah. So this article is from Philadelphia and New York, and they have reviewed all the articles on limb lengthening and deformity correction, which were published from 2013 to 18. And they wanted to find out what was the new advances in this field. So they have divided, taken up all the patients, whether they were congenital limb deficiencies, whether they were developmental deformities, or even metabolic, and reviewed the articles. So I have just divided them into groups. So the articles on growth modulation I'll discuss first. So again, for limb length discrepancy, growth modulation, there is still a lot of controversy. When should we operate? Whether it's a temporary, we should use a temporary method of epiphysiodesis or permanent, and whether that temporary method actually remains temporary. Whether it causes a permanent growth arrest is still a point of controversy. The choice of implant, whether to use a staple, to use a 8-plate or a percutaneous transphysial screw, and how to follow up these patients. So they were initially, in 2013, there were articles which were in favor of tension band plating to be used for limb length discrepancy. And Likisas, he found that there was no difference between staple, 8 plates, and transphysial screws. But there were again articles which said that transphysial screws were better and then tension band plating, and tension band plating was not that effective. Stewart showed that physial ablation gave a better results, and 8 plates were not that effective, and they were not predictable. But the problem with all these articles was that the number of patients included in the study was too small to draw an inference. So from France came this study in 2016 by Gametou, who reviewed 40 patients which were treated with tension band plating for limb length discrepancy, and it included a varied diagnosis. It included developmental anomalies also. And he inferred that permanent epiphysiodesis was better than the reversible methods. If you want to use a reversible method, then transphysial screws are better for treating limb length discrepancy than tension band plating. And this was again confirmed by another article by Behan. And this is very important. The correction, they say, in a reversible epiphysiodesis, it happens between 6 to 18 months. So he said that if you want to use a reversible method of epiphysiodesis for limb length discrepancy correction, we should plan our correction taking into account this period. So if the remaining maturity growth is 2 years, we have to take into account that the correction will start happening after 6 months and probably will also happen within 15 to 18 months. So they did not see any correction for 6 to 12 months also. And then the correction happened. They also said the parallel versus divergent, putting the screws parallelly or divergent, it did not make a difference. And again, they concluded that 8 plates at best are unpredictable in treatment of limb length discrepancy. Again, this was corroborated by Lee, and he said the staples are superior as compared to tension band plating. And the problem with tension band plating, he said, was a volcano effect. That means the screws were inserted from the medial and the lateral side. So the central epiphysis, it showed growth, and the peripheral epiphysis did not grow, which they attributed to a volcano effect. And they said that is what defers the correction and does not let the limb length discrepancy get corrected. Sinha, he went ahead and he said that these tension band plating, when used for limb length discrepancy, they cause a intra-articular deformity. So what he did was he measured the medial and the lateral slope of the proximal tibial physis, and he found the roof angle by subtracting the sum of medial and lateral proximal tibial physial angles from 180 degrees. So he found that the slope had increased and the roof angle had decreased in a significant number of patients. So he said that the proximal tibial physis is basically a triangular physis, and that is why this happens. And so he recommended that if you want to use a tension band plating for LLD, you should use quadrilateral plates to cover more area of the proximal tibia. But they concluded that the tension band plating is ineffective for the treatment of limb length discrepancy. So recently there is a consensus in which tension band plating for LLD is not a very good choice. But for angular deformities, tension band plating still is a very good procedure with low complication rate, very predictable results, except when there is weight related complication. So for patients with high BMI index, they this study recommended the use of non-cannulated screws for overweight kids. Sweeney, this was a very original article by Kyle Sweeney, in which what they did was they tried to decrease the radiation in the follow-up period when tension band plating is used for limb length discrepancy. So they tried to correlate the divergence of the screw and correlate it with the correction which was achieved. So they found that the linear aggression analysis revealed that for every 1 degree change in the screw divergence, there was a resultant 1.8 degrees change in the tibiofemoral angle and 2.1 degree change in the LDFA. So they said that for every follow-up, you need not take a full length scanogram, which will increase the radiation. A simple AP view and measuring the screw divergence, you can actually correlate how much correction has happened. So this study was will be useful basically while following up with the patients with the angular correction. Again for angular correction also, if you are treating a child which is close to skeletal maturity, transphysial screws have been proved better than 8-plate because they cause a faster rate of correction. Also, Fair and Leville, they harped upon the rebound phenomenon after 8-plate, and they found that the high BMI index and the severity of the deformity correlated directly with the rebound phenomenon. So if the deformity was more than 20 degrees at the onset, there was a increased frequency of rebound which was greater than 10 degrees compared with the patient who had less degree of deformity. Also, if you treat the child at a younger age, there is high incidence of rebound. And if you treat the child at a later stage, specifically if there is less than 1 year at the time of removal of the 8-plate from skeletal maturity, then the rebound doesn't happen. But if there is more than 1 year of growth left when you have removed the 8-plate, there is a high incidence of rebound phenomenon. For limb lengthening, as we all know, the recent consensus is going towards intramedullary motorized nails for limb lengthening. So there are multiple studies which have been published during this period, which have shown their results. Noteworthy is this study by Hoon, in which he evaluated 50 consecutive lengthenings, and he corrected the deformity as well as lengthened the limb with an externally controlled motorized intramedullary nail. What he found was that the lengthening achieved with the nail was adequate, so they could achieve within 3 millimeter of their target of lengthening. But with the deformity correction, there was some amount of undercorrection, and sometimes unintended deformities were also created while using a nail, but they said that it was not of clinical significance. Obviously, they found this technique to be better than the external fixator in terms that the number of complications were less, the patient comfort was better. The femoral lengthenings, they healed better than the tibial lengthenings, and they made a technical note that whenever you are using a femoral antegrade nail for lengthening, the entry should be through the tip of trochanter in skeletally immature to avoid proximal femoral varus. So in few of their cases, they made the entry through the piriformis fossa, and which created a femoral varus deformity, which was unintended. Again, another study by Lopes, he used precise nails to correct the deformity and lengthen. Again, the same, these two studies are very comparable. They also found that the lengthening was achieved adequately, but in 80% of their cases, only they could achieve a satisfactory correction of the deformity. So basically using a nail for deformity correction and lengthening, it basically the limitation is the severity of the deformity. And when I read the two studies, I found that both of these studies, the mean deformity, the angle of deformity was not more than 20 degrees. For severe deformities, using a nail and achieving the deformity correction as well as lengthening becomes a little bit difficult. Also, this study, it emphasized the use of polar screws, which are multiple blocking screws to achieve a good correction, so that they could control the passage of the nail in the intramedullary canal. And also they used a temporary intraoperative fixator to assist for the correction. So the study by Steger then went ahead, and what they did was for severe deformities and for deformities with dual cora. So for example, this case, there is a proximal tibia deformity and there is a diaphyseal deformity. So what they did was they corrected the proximal deformity with a plate and then used a precise nail to correct the distal valgus deformity of the tibia, diaphyseal deformity, and then lengthen over it. But they said this required a lot of pre-operative planning, as well as surgical skills were tested while doing these cases. So this is another way we can take care of the severe deformity and still lengthen by an intramedullary nail. Another study, they studied the effect of they studied the nails while removal, and they found that all these nails, they showed internal corrosion, as well as there were a few pieces of external corrosion also, which was reported. So they recommended that these nails should not be reused. So for every case, you should use a new nail. So the possible implant failure then will decrease, because these nails also, they corrode. For congenital deformities also, these nails have been used for limb lengthenings, and the results have been, the initial results are better than the external fixator. Again, in the form of the range of motion exercises, there are less fracture chances after removal of nail, and pin tract infections, as well as knee range of motion and contractures. So these two studies, they evaluate limb lengthening techniques, and they found use of an external fixator resulted in decreased range of motion during distraction and after consolidation, as well as increased total problems due to pin site infection compared with the motorized nail group. There were, again, during this period, there were multiple reports of lengthening with fixator also, which were published. And one important finding which I found was that lengthening of more than 6 centimeter in a CFD patient, or more than 25% of the femoral length, these were associated with a low patient report score. So although the success according to the surgeon and according to our criteria was achieved, but the patient scores, the patient satisfaction went down when the lengthening was achieved for more than 6 centimeter. And they recommended that the regenerate in cases of CFD should be supplemented by an intramedullary nail or plate to prevent the chances of refracture. This is an interesting study which came from Steiner's Hospital, in which they used botulinum toxin A, or the Botox, and they used it in the dose of 10 units per kg for a maximum dose of 400 units. And they used it at the end of the procedure. So they did a double-blind trial in which half of the patients were given Botox and half of them were given just plain saline placebos. And they found that the pain on the first post-op day decreased significantly, although there was no difference in pain in the further post-op periods. But there were a lot less pin tract infections in tibia, and the patients, they reported a better quality of life, which was assessed in the terms of pain as well as the range of motion. So patient was much more comfortable in the in this group in which Botox was used. So what they did was they completed the procedure, and for a femoral lengthening, they gave Botox into the rectus as well as the hamstrings, And for tibial lengthening, they injected the Botox into a gastrosoleus. So this is something new which is being used. For hemimalias, usually it was Peli who was published in 2016, the new classification of tibia hemimalia. Otherwise, the rest of the things are more or less we know about. So in Blount's disease, Taussig, he studied the prevalence of hypertension. So what he hypothesized was that obesity is a risk factor for Blount's disease, but not all obese patients, they end up with Blount's or a SCFE. So he said there must be something else to it, and he studied hypertension, and he defined hypertension as or pre-hypertensive state as more than 90th percentile. When he compared the same population for sex, age, and gender, as compared to the normotensive population, and they found 64% of the patients who were with Blount disease were affected with pre-hypertension or hypertension. And patient diagnosed with either SCFE or tibia vara had 2.5-fold higher odds of having high blood pressure. So this now becomes a very important finding. So if a obese child who is detected with hypertension, so it becomes a modifiable risk factor to probably prevent the occurrence of SCFE or developmental tibia vara at a later stage if we can detect it early. So this was a nice study in Blount's. Again, Blount's treated with growth modulation, as Dr. Tushar sir also mentioned the study. The attention band platings are not very effective. Obesity and severe deformities become the risk factor. Undercorrection and implant failure were the main issues, and they have recommended the use of dual plates, quad plates, and solid screws if you have to use a tension band plating. And osteotomy becomes still remains the mainstay and becomes the salvage procedure also. And there was a study by Sesh which said that if you only want to correct tibia vara with osteotomy, you don't need to osteotomize the fibula. But if you want to incorporate the correction of internal torsion, that is a rotational correction, or if there is a severe varus, which they have not defined what severe varus is, so fibular osteotomy is required. For metabolic conditions, this result of this is a study from Ahmad Anam, and they reviewed their results a decade before of osteogenesis imperfecta and rodding, and they changed some protocol. The protocol changes was that initially they used to use palmitonet acid for infusions. They started using zolentronic acid, and they stopped the infusion after 4 months. 4 months after doing the osteotomy. So they stopped the infusion for 4 months. And initially they used to use a saw and they started using a osteotomy, and they found that their results changed significantly after changing the medical and the surgical management, and delayed healing, which they had seen in their initial results, it decreased significantly. However, the delayed healing still is a problem with patients with OI who are on infusions. So you can see the fracture line for a good amount of time. This is a article by Khalid Azam. He reviewed his results of rodding in children with OI of femoral and tibial osteotomies, and he said the revisions were required in 53% of the patient, which occur at a mean time of 4 years and 4 months after the initial rodding. In most of the cases, revision surgery was related to patient growth and subsequent fracture, although rod migration did occur in a minority of patients. Non-union or incomplete union was 14.5% in this series. There were 3 groups which reported their results on X-linked hypophosphatemic ricket, and here tension band plating or reversible epiphysiodesis remains the mainstay of the treatment. They said the valgus deformities and the children with more than 3 years of growth remaining, they corrected better. But the problem with this is if you correct these kids at an earlier age, you should be ready for the recurrence and you should explain the patient. So early age of recurrence was associated, early age of correction was associated with recurrences, and late age of correction and a good metabolic control, it improved the results. If at all the fixator has to be used in these conditions, it has to be supplemented with a intramedullary nailing to prevent complications such as refracture. But even in this study, the number of complications using a fixator for hypophosphatemia rickets were very high. For CPT, so CPT still is a problematic condition, and there is Liu studied whether we should operate the child with CPT before 3 years or after 3 years, and they found out that in both the groups they achieved union in more than 90% of the cases, and the complication rate was same if you whether you operate the child before 3 or after 3. So they said there is no indication to delay the surgery in these patients. This is an article by Stephanie Penier. Although they had only 5 cases and all 5 of them achieved union, what they did was they treated CPT in 2 stages. In the first stage, they excised the pseudoarthrosis, put a nail, and then put a cement spacer and put a cast and leave the child for 2 months. During this 2 months, they have allowed the child weight bearing. After 2 months, they took the child for another surgery in which they filled the membrane with posterior iliac crest grafts, and then again casted the child with a full length AK cast. And this time they did not allow weight bearing and achieved union. So they have these 5 cases and all 5 of them have achieved union. So this is an induced membrane technique which they have published. This is an article from Manipal, Dr. Hitesh and Dr. Benjamin Joseph. Now, this is a very interesting read because they have studied the factors which influence the union and refracture of CPT. And they found that if you use Elizaro technique, you transfix the ankle and subtalar joints, you put a cortical graft, and you don't osteotomize the fibula unless the fibula pseudoarthrosis is there, then you have to do it. But if it is not, you should not osteotomize the fibula. So these were the factors which improved the result in CPT, while the use of bone morphogenic protein and combining intramedullary nailing with Elizaro technique were shown to have poor results. So this is again contrary to what we use right now. I mean, the Peli has shown such good results, and we most of us we use an intramedullary nail and supplement it with a fixator, which is mostly an Elizaro fixator. So I have not gone through the whole article, but this is what they have concluded in their study. So summarizing, reversible growth modulation is a good technique for angular correction, but it is questionable for LLD, limb length discrepancy. If you have to use, then PETS has a faster rate of correction and should be used. Intramedullary lending nails are the future, but again, cost and availability in our country is a concern. And external fixators for limb lengthening and deformities have stood the test of time, but they require a great deal of operative planning, pre-op planning, good execution, excellent follow-up, and above all, a motivated patient.
Yeah, Kirti, thank you. So these are many of these we already use, and there were some new revelations. And thanks for reviewing this. Yeah, Tushar, you have.
So most of you have been earlier advocating external fixators. So now in the newer techniques seem to be wanting to drift away from external fixators. I think that from Herzenberg's course also, that they are trying to control the indications more and more in which they will apply external fixators.
In favor of the lengthening nails, you see.
In favor of various other, even for deformity corrections, wherever it is possible, either decrease dramatically the fixator time or to not apply it at all.
Right. So even yeah, sir, go ahead.
No, please. Yeah. Kirti, answer, and then it's a different.
Yeah. So even in the paper which they studied the use of intramedullary nail for deformity correction and lengthening, when I saw the the images which they had shown, the amount of deformity is very less. So these deformities can still be controlled with a nail, but whenever you are come across a multi-apical deformity, or you come across a severe deformity at a single cora, the use of these nails, I don't think, sir, will be very feasible for deformity correction and lengthening. I agree, for lengthening, these are good nails, and because it's an intramedullary device, it must be comfortable to the patient. The chances of contractures and physiotherapy rehab can occur much better. But I don't think for deformity correction and lengthening, this still is a good choice.
So one of the gap between what is the new literature on limb lengthening and our country is that most of the new literature involves self-implanted, self-distracting nails and the Taylor's spatial frame, the 6-axis correction. And because of the cost constraint, both these devices become difficult in a country. And we are still using the traditional ways of lengthening. Either we use Ilizarov or monolateral fixator. And most of us now use lengthen over the simple rush nail, or I use nowadays plates most often after I finish lengthening. So, that literature will not be available that much because the entire paradigm of lengthening has shifted, in Western countries, which publish maximum. Yeah. Tushar, you wanted to say something?
So how many of us actually use the ortho SUV?
I have 100% success rate in one patient. One. So it's not easy. See, for simple lengthenings, you would not use it because it is very intensive. You have to have one person, constantly monitoring. Patients really don't understand it, and you have to be so much involved. So I think for simpler deformities and lengthening, you would do deformity correction and lengthening all in one go using the fixator. But this will be for complex. So we used a very severe blounds, and I was very happy with the way it came about. But it does require a lot of monitoring. Every week you need to recalibrate and calculate rate of it. Yeah. Yes, Kirti.
Any comments on this paper from Manipal, where they have said that if you combine intramedullary,
yeah, we'll have to read that. Yeah. Doesn't seem logical, but because we need comparison. So Pele has been using plates, and the problem with plates instead of external fixator is that the tibia is very small, and the plates available with us are very big, and that limits the area which you graft when you use an LCP in exchange for an external fixator. I would still use external fixator because that allows compression and it allows you more area for grafting. I think Mandar, you have used, right, plates with. Yeah, Jayant wanted to say.
Hello. Yeah. So, I mean, I've been the times when I have not used an Ilizarov with the telescopic rod, I've always regretted it. So some form of external fixation, I feel helps. But I think plate is less cumbersome. So if we can design a small enough plate, I think that would be a good option. But I think supplemental fixation is essential because just the intramedullary nailing is not enough. So we need to really, I think next time we will review this paper or whenever there's an opportunity, we'll review this.
Go ahead, we'll add this. Just Kirti, just send us the reference for this paper, and then we'll ask Jayan to review it. So something again, I am finding less articles and less research on a technique which is very easy and challenging are PET screws. I've completely, almost 90% we have converted to PET screws from 8 plates. And I find it's very easy to use, very patient friendly, easy to put and remove. And sort of now, after doing almost more than 50 cases, we have perfected the art of PET for angular deformity correction. So I'll talk about it sometime, what are the tricks, how do you do it exactly, because the method is not described anywhere. And the number of papers are few. So I was happy to see there were at least few papers which said PET screws are better than 8 plates for limb length discrepancy. But it's very important method in, as compared to 8 plate, PET screw, I feel works better, even genovalgum correction.
Yeah, so these papers have mentioned that if you want to a faster correction near to skeletal maturity, PETs is the way to go.
So somehow our patients come just near skeletal maturity, very near to it. So sometimes 8 plates don't give complete correction, but 8 plates, give a faster correction and they are more patient friendly. Though recently we have compared in a paper, I think Jaideep is writing up, where we are seeing after doing an 8 plate or a PET screw, how soon you gain the range of movement, how soon the child becomes pain-free, how soon the children start stair climbing, going to school and take part in sport activities. Because we promise them that, this is a smaller procedure. Next day, everything is okay. It's not so. It takes time. Patients are painful for almost a month, and they take almost 5 weeks to go to school, not before that. And sports is almost 3 months. So it's not that it all happens very fast, but we found that PET screws are better than 8 plates as far as post-op return to school being pain-free and knee range of movement is concerned. Okay, so shall we end? It's almost 8:22. So let's next time, I think because since all of us have started working, let's keep time 7 to 8 and design the program along with it. I'll put some questions on the group. So please answer so that we can design this session better. I think next time it's going to be solo performance by Samir. So he's going to review first session arthrogram and then MRI, role in DDH. So this will be done on Tuesday and Friday. And I think we'll allow him almost 40 minutes for presentation, and let's have 20 minutes for discussion for both the sessions. Okay, chalo. Thanks.
Sir, I'm not going to do all the articles. Some articles, others are also.
Yeah, we will help you. Don't worry. Okay.